In understanding the clinical course of multiple sclerosis, it is essential to recognize the evolution of conceptual models. Traditionally, MS has been categorized into distinct phenotypes: relapsing remitting, secondary progressive, and primary progressive. In this classical framework, relapses are primarily attributed to inflammatory processes, acute episodes of immune-mediated demyelination, while the progression phase reflects ongoing neurodegeneration, leading to a gradual accumulation of disability. This model provides a straightforward clinical schema, facilitating diagnosis and management. However, emerging evidence challenges this dichotomy. A more contemporary, unified perspective suggests that inflammation and neurodegeneration are not mutually exclusive phases, but coexist throughout the disease course. This paradigm is supported by converging data from genetics, epidemiology, immunology, and pathology, indicating that inflammatory activity persists even during progressive phases. The key takeaway here is that the traditional subtype scheme, while still useful clinically, may oversimplify the underlying pathophysiology, highlighting the importance of considering a continuum rather than discrete stages. Turning to relapsing remitting MS, which accounts for approximately 90% of cases, the hallmark is the occurrence of discrete neurological attacks. These episodes typically evolve over days to weeks, rarely hours, and are characterized by new or worsening neurological deficits. In the early stages of MS, recovery from these attacks can be substantial or even complete, often within weeks to months. Yet, as the disease progresses, subsequent attacks tend to leave less residual deficit, and subtle subclinical progression, referred to as silent disease activity, may occur even when patients are relapse-free. This phenomenon underscores that disease activity is not solely reflected by overt attacks, but also involves ongoing neurodegenerative processes. It is also important to clarify terminology. Relapsing MS, or RMS, encompasses all patients with episodic attacks, covering both relapsing remitting and secondary progressive patients who still experience attacks. This broader classification emphasizes that even those in progressive phases may retain some inflammatory activity. Moving to secondary progressive MS, which always begins as relapsing remitting, the clinical course shifts. The hallmark becomes a progressive deterioration, an insidious decline, unrelated to acute attacks. Patients develop greater fixed neurological disability, such as persistent walking impairment, which cannot be solely explained by prior relapses. Clinically, this is supported by measures like an Extended Disability Status Scale, or EDSS score of greater than 4, combined with a Functional Status Scale, or FSS motor score of greater than 2. Historically, the risk of progression was about 3% annually, but with current therapies, this risk has decreased to less than 1% annually, reflecting advances in disease-modifying treatments. Primary progressive MS, accounting for roughly 10% of cases, presents a different clinical picture. Patients do not experience discrete attacks. Instead, they exhibit a steady decline in function from disease onset. Interestingly, the sex distribution in PPMS is more balanced compared to RMMS, and the disease tends to manifest later, around 40 years of age. The progression to disability tends to be faster relative to the initial clinical presentation. Despite this, the underlying pathology remains the same as in other MS forms: communal neuroinflammatory and neurodegenerative processes. Notably, some PPMS patients do experience relapses, and the term active progressive MS refers to patients with progressive disease who exhibit new MRI lesions or relapses, indicating ongoing inflammatory activity even in the progressive phase. Finally, a critical aspect of MS pathophysiology involves the mechanisms of disability accumulation. Disability can increase due to two primary processes. First, relapse-associated worsening, or RAW, where deficits from an acute attack may not fully recover, leaving residual impairment,
And second, and more insidiously, is progression independent of relapsing activity, known as PIRA, or progression independent of relapsing activity. PIRA reflects ongoing neurodegeneration that occurs silently, without clinical relapses or overt MRI activity, and is now recognized as the main driver of disability accumulation across all MS phenotypes, including RMMS, SPMS, and PPMS. This silent progression raises profound questions. If PIRA can occur unnoticed, does this mean that the traditional clinical distinction between relapsing and progressive MS might be more blurred than previously thought? Indeed, if PIRA signifies early SPMS, then the onset of progressive disability may begin much earlier in the disease course than clinical observation alone suggests.